So as I mentioned, we are closing this afternoon with two case study speakers, and I'm going to invite Will Parsons up first to give you case studies, and then we'll have one more and we'll do Q&A with the two of them, because I think they'll go together nicely in terms of a conversation. Will Parsons is a pediatric oncologist at Baylor College of Medicine, as well as the Texas Children's Hospital. And I think that we're going to hear from, in your case studies, that we had a chance to talk a little bit earlier today, and I think that we're going to hear about a good bit of progress, which is exciting, but a little bit of a reality check and still some hurdles remaining.
Yeah, we'll focus a little bit on what the challenges are related to the interpretation of these results.
Okay, good. I give you Will Parsons.
All right. All right. It's a great honor to have the chance to talk to you today. I'm a pediatric oncologist, so I take care of children with cancer. I'm also a cancer genomics researcher, and my career and my research interest is related to trying to figure out how to clinically apply the types of results we've been talking about today to take care of our children and take care of these patients. So I'm not going to give any significant amount of introduction about cancer, how it's a genetic disease, or the efforts that are going from the huge genetic complexity of cancer and the huge complexity of individual patients down to trying to figure out specific genetic alterations that will guide what therapies we give. Suffice it to say, that's the challenge we've been talking about all day. A couple of notes on pediatric cancer. I'll give you a 30-second primer so you can be expert. Comment number one is that children get different tumors than adults do. So there's some overlap, but in general, there's a large number, especially a number of these sarcomas, et cetera, that are much more common in children than in adults. So we need to be thinking about different strategies and different drugs and different treatments in children than in adults. The second is, if you look on the left side here, going along with these different tumors, there's a different genetic basis for these cancers. So this just shows on a graph the number of mutations that are found in a typical exome sequencing study of an adult tumor, so say 50 to 100 for most of those, versus a pediatric cancer, where you have at most a small handful. So you have different types of genetic alterations, fewer mutations. In addition, even for those tumor types where both adults and kids get the same kind of cancer, so glioblastoma or GBM for one example, different genes are mutated in the adults and the children. So there's a number of the classic oncogenes, tumor suppressor genes, et cetera, that are much more commonly mutated in adult tumors, and others, such as these genes that were already referred to earlier today relating to mutations of histone complex genes, that are almost never seen in adult tumors but are very frequent in kids. So it's really just a different clinical and genetic context. The last comment I'd make is that even more than in adults, we need to be thinking about not just somatic mutations, or not just mutations that have occurred exclusively in the tumor, but mutations that are also present in the germline or in the other normal DNA of the individual. So this is just an example of the first patient who was enrolled in the study I'm going to talk about today. And while this child was being treated for their cancer, mother was being treated for their breast cancer, and basically all these green and yellow indications are all various cancers in this family. So inherited and de novo inherited cancer susceptibility mutations are very important. So the results I'm going to be talking about today, the three cases, are all coming from a series of case studies, and it's part of this project we call Basic 3, which is a project trying to assess the clinical utility of genomics, specifically the test we're using is exome sequencing, in the pediatric oncology clinic. And so it's a partnership with my partner Sharon Plon, who's a clinical geneticist and cancer genetics researcher, and along with a large team of people who I'll show at the end. So the study basically is this. We're enrolling newly diagnosed solid tumor patients at Texas Children's Cancer Center, so roughly 280 over a couple of years. We obtain blood and tumor samples. Those go to the clinical lab, so not being done in the research context, but in a CLIA-certified lab, having both tumor and blood exome sequencing done. The lab generates clinical reports, as they do for other folks who are ordering this clinical test. Those results go in the medical record. They're shared with the oncologist, along with some feedback and interpretation. And then the oncologists, along with the genetic counselors who are specific to the study, return those results, both the tumor and germline exome results, to the families of our patients. and explain what action needs to be taken, if any, and interprets the results for them. Then we follow these patients over a couple of years, with the primary objectives being related to figuring out how often can we find useful information from this sort of interrogation of the patient's tumors. How often can we find useful information from looking at their blood, either in terms of the tumor side, how often we can see results that have some potential impact on selection of drugs that might be used if that patient's tumor came back. On the germline side, how often do we see inherited cancer susceptibility mutations? How often do we see other incidental findings, so medically actionable findings in non-cancer genes? And then finally, we're trying to evaluate the impact of these results, not but just on the patient, but also with the input of the families and the oncologists. So in fact, in this study, we enroll not just the patients, but also their parents and also the oncologists. And if you haven't ever enrolled your colleagues on a study, you've missed something, I can tell you that. So this is the first case. It's a 14-year-old girl with leg pain. So as a 14-year-old girl, she came to the emergency room with a 2-month history of worsening leg pain just above her knee. There's no family history of cancer. The exam was notable for some tenderness right above the knee, no real swelling, no warmth, etc. This is the plain x-rays, and you can see there's some abnormalities right here up above the knee, and you can see that also looking at the side, from the side in the lateral view. The MRI scan, this is the right leg, showed a very large, heterogeneous, ugly-looking tumor. This is the same tumor in cross-section. And then also, when we staged her to look for evidence of metastatic disease, saw that there were, you can see this tiny little white dot here, there was some evidence of metastases to her lungs. So the presumed diagnosis was a bone tumor osteosarcoma with metastatic disease. The pathology confirmed that, so showing the typical small round blue cells of osteosarcoma, some of the osteoblast formation, etc. And then this is what old school genomics would look like and would tell us. And that is essentially showing a complete mess. So instead of having 2 with each of these chromosomes, many of them have 3, some have 4, some only 1. And it's never good when on your photo you have a whole bottom row, which are things that can't really be identified. So a complete mess, not really targeting specific genes, but typical of what osteosarcoma looks like. So the diagnosis, metastatic osteosarcoma, the treatment the patient gets, chemotherapy, and then a definitive tumor resection, limb salvage therapy in this case, and then more chemotherapy. Despite all that, the prognosis is really quite poor. So this is a survival curve. The top curve shows what happens for osteosarcoma patients without metastases, so a significant number can be cured long term. The bottom curve shows the impact of the metastatic disease on this patient, and it's obviously a much worse prognosis. So it's a case where we're interested in finding answers. So here's some of the results of the exome sequencing on the tumor in this case. On the left side of the screen, it's a little bit difficult to see the details, but essentially it's a list of some of the characteristics of the mutation. First identified was somatic P53 mutation. On the right, and for those of you who've never looked at this sort of data, I'll give you a brief guide through. This is essentially showing the mutation sequencing reads using next-generation sequencing. So each of the rows is a specific read. The blue are going in one direction, red in another direction, which is irrelevant. And then you have the normal on top here, and we're looking at a specific position to see if there's any mutations in this case. So that was the blood sample. There was nothing seen. But if you looked on the tumor, there were a number of, you can see, small green base changes here. So it's a single nucleotide change causing this amino acid change at position 248. A well-known P53 mutation does have some impact on prognosis. It's thought to be even worse potentially for the patient, although probably not greatly different than their current prognosis. In terms of picking therapies, though, it doesn't help us very much in that we don't have good drugs targeting P53. A second mutation was more interesting. So it's a gene called TSC2, classic tumor suppressor gene. It's the gene, one of the genes mutated in tuberous sclerosis. And it was found to be a 2 base pair deletion, so nucleotides 2764 and 2765 deleted, which causes a frame shift, truncating mutation, presumed inactivation and loss of this protein function. So again, these are the normal reads on the top, so the mutation is not seen. Down the bottom, you can see these white gaps, which are indicative of those 2 bases being lost, a frame shift mutation. And you can see it's, even though it was only presumably present in one of the 2 alleles, it's in almost all of these reads here, implying that not only there's this mutation on one copy of the TSC2 gene, but the other copy has been lost, as you often would see classically with a tumor suppressor gene. looking at the cosmic database to see how often this gene has been mutated in these types of patients. You can see it's hard to read, but the asterisk right here by bone. 42 patients' data as it was in the database, no mutations in TSC2 reported, although you can see there's somatic mutations in TSC2 reported in a decent minority of patients with a large number of diseases. And it's an interesting gene for us, obviously. So as many of you in the audience may know, the tuberous sclerosis complex, which is pretty complicatedly drawn here, but in the middle you have TSC1 and TSC2. These two genes in this complex are the primary inhibitors of a gene called mTOR, which activates many oncogenic pathways. And so in patients who have tuberous sclerosis, they have homozygous loss or deletions or mutations of these two genes, such that this inhibition doesn't occur, mTOR is always active, and then they get a variety of different mutations, one called SEGA, which is a type of brain tumor, which we'll look at in a second, and a number of others as well. So in this case, it's interesting, not just because of the biology, but also because there are mTOR inhibitors in the clinic, obviously. And so rapamycin is one that was listed here in this slide, but there's other options. And so in a patient like this, you could consider using one of these mTOR inhibitors to target the effect of the mutations in the TSC1 or TSC2 genes. And so for patients with tuberous sclerosis, this is actually what is being done. So this is a picture of a SEGA, or a subappendable giant cell astrocytoma. There have been a number of clinical trials, both small-scale studies up to a recent phase 3 study, a large number of patients published in Lancet, showing mTOR inhibitors can be used to treat these tuberous sclerosis-related tumors, using this logic exactly as we said, such as SEGA. That has led obviously to FDA approval of this drug for treatment of those tumors. And so the question is, in a patient like this that doesn't have germline mutations of TSC1 or TSC2, but they have somatic mutations in their tumor, presumably the same circuit is activated, and potentially we can think about using that as a treatment. So the clinical summary: patient has metastatic osteosarcoma. We have a poor prognosis. We found an unexpected TSC2 mutation, a frame shift and activating mutation. And so the clinical question, and we'll get a little bit to this more in the challenge at the end, is how to deal with this. We have mTOR inhibitors. When should we use them? Should we use them in combination with standard chemotherapy? Should we use them after they finish their chemotherapy? Should we use them only if the patient recurs? Should we use them in combination with other targeted therapies? These are all the studies and the data that we don't have. So trying to figure out for each of these patients what to do is the challenge, and it's an ongoing case. The second example is this. It's a 7-year-old little boy. He presented with a belly mass. He hadn't been eating well and had some other symptoms for a few weeks and months, lost some weight, and his pediatrician felt a mass in his belly. Again, no family history of cancer. Exam was notable for a big belly in this tumor, and this is what the MRI scan showed. So this is on the right side of the patient's abdomen, a huge heterogeneous abdominal tumor in the liver. Again, it's a patient, when we scanned the lungs by CT scan, we could see an abnormality indicating a metastasis. So another difficult case for us. The pathologist said, yes, this is a liver tumor and it looks malignant, but they couldn't tell us exactly what it was, whether it was a hepatoblastoma, which is the most common pediatric liver tumor, or hepatocellular carcinoma, which is what you more commonly see in adults. And this is a case where diagnostically, the tumor information helped to some extent, because what we found here was a mutation in a gene called NRAS, and you were just hearing about KRAS and have heard about other types of RAS as well. So again, this is what the sequencing reads look like. On the top, you have the normal sample, so no mutation. On the bottom, you have various reads from the tumor that have this mutation. It's much more commonly been reported in other tumor types, melanoma most prominently, so a lot of the information about targeting this pathway and how to treat these patients is based on that different tumor. So the question is how we apply it here for these patients. It has also been reported in a number of other cancers, including hepatocellular carcinoma. And this patient's response was more typical of a hepatocellular carcinoma, and that progressed right through chemotherapy. So they were treated with 3 cycles of our standard treatment, had surgical resection of the tumor, essentially took out that whole section of the liver, 4th cycle of the chemotherapy, then the lung metastases increased. The patient was enrolled on a phase 1 trial, which coincidentally, because we didn't yet have this information about the NRAS mutation, was using an oncolytic virus, a phase 1 study of an oncolytic virus to try to try to specifically target cells that had an activated RAS pathway, which is known to happen in these types of tumors. The patient had 1 course of this, wasn't seeing much response, had further progression of the lung metastases, and then their clinician tried to decide how to use some of the rest of this information, so the results of the exome showing the NRAS mutation. So we've probably seen some slides like this before of these pathways today, probably already showing this particular pathway. So there are a lot of downstream effectors of RAS, PI3K, RAF, etc. So one question then becomes, if we're not that good at targeting RAS specifically, how do we target some of these other genes, and what combination would we use the inhibitors? So in this case, the clinician chose two FDA-approved, clinically available inhibitors, sorafenib, which targets RAF, rapamycin, which targets mTOR, with the idea that he would be able to block, ideally, both of these pathways, at least on this nice diagram, and then also treat the patient. The fact of the matter is the patient's disease was progressive. They were unable to tolerate even taking the medications, and so we didn't find out what the results of this experiment would be, which is obviously sad on multiple levels. But so these are the examples of the complexity of trying to interpret this data, and hopefully, as we continue to match both clinical information and this genetic information, we can try and figure out what works and what doesn't for individual patients. So as a refractory liver tumor, patient died, NRAS mutation. The question is, how do we target this unexpected activated pathway that we found? The third case is also a belly tumor, in this case a 9-month-old boy. Had been previously healthy, had a couple-week history of some problems. Again, no family history of cancer, no congenital anomalies, nothing else wrong with the child that we could tell, which comes back as being relevant in a moment. And the exam here showed a large abdominal tumor over on the right side. So this is the left kidney, no right kidney visible, essentially this tumor involving that tumor, or that kidney. So the kidney came out as well as some lymph nodes. The diagnosis was a Wilms tumor, which is the most common kidney tumor in children. There was some gross spillage of the tumor into the abdomen, which made the patient a higher stage cancer. The treatment for that is a bunch of chemotherapy and then abdominal radiation therapy. So the patient is currently doing well after receiving all of that treatment. So this is a case where the tumor results were somewhat interesting. They showed a beta-catenin mutation and activation of the Wnt pathway. But the germline results are potentially even more interesting. So unfortunately, in this case, as opposed to the others, the tumor is on top and the normal is on the bottom. I apologize for that. What you can see, first of all, is if you're looking at the normal first, you see there's this small deletion. It turned out to be a deletion of 3 nucleotides, insertion of 2 other nucleotides, but this is present in the germline. So this is present in the blood sample. Excuse me, I shouldn't say germline, in the blood sample from this patient. Then when you look at the same mutation in the tumor, it's also present in the tumor, but in virtually all of the reads. And it turns out that this mutation seen here is a mosaic mutation in a gene called WT1, which is associated with Wilms tumor. And the fact that it's lost in the vast majority of the tumor reads goes along with it being a tumor suppressor gene causing renal cancers. The interesting things here are several-fold. So in addition to having a mutation WT1 and seeing that mutation is in essentially every one of the tumor reads, implying this is acting as a tumor suppressor and the other allele has been lost. When you look at the blood, instead of the expected 2 alleles, you can actually see 3. So you have rows, whether they be blue or red, that don't have any notation or any markings in them, and those are the wild type sequence. Secondly, you have rows that have the small white blank here, which is the insertion deletion mutation. And then thirdly, which might be hard to see, there's some rows that don't have the deletion but do have a single missense. It's a common SNP actually at that site. So there are 3 different alleles in this case, which just shows some of the complexity of what you can find in these situations. So not just finding germline or inherited cancer mutations or even de novo mutations, but find mosaic mutations. So for those who haven't been thinking about this lately, this is what happens when you have a mutation occurring in one of the cells in a phase of early development, and then all the daughter cells, so to speak, going on from that particular cell can have the mutation. And so in this case, if you have that, and it's a WT1 mutation in the kidney, or affecting other organs as well as the kidney, you can get this tumor. And the one other point I'd make is technically we're now in the time where we can find all these results, whether we expect them or looking for them or not. So this is what the Sanger sequencing, as an example, looks like, where if you were talking about some mutation or some change that was only in 2% or 5% or 10% of the DNA reads, you would never see it. But if you're piling up next generation sequencing reads, you can see normal reads, you can see reads with one mutation, and then rarely you can see the others. So we're able to gather much more information than we ever previously would have. So these germline inactivating WT1 mutations are known to predispose patients to Wilms tumor and also to other genitourinary anomalies. Most importantly for our patient, if we know that they have these mutations, there are actually clinical actions we take in addition to treating their cancer. So number one, they have a much higher risk of developing tumors in the other kidney. So in terms of the surveillance and screening of looking for additional tumors, that's part of the plan. Secondly, they have a risk of renal failure unrelated to the tumor itself because of this mutation. And so it's a patient will need to be screened for renal function long into the future. So again, there's a third case with Wilms tumor, had a complete remission. In this case, instead of being a somatic or a tumor-specific mutation, it was a mosaic mutation of WT1. And the clinical recommendations actually changed for this patient based upon these germline findings. So in conclusion, just gave these cases to give a couple examples of the types of information we're gathering. It's an ongoing study because we're getting this using currently available techniques. We're able to assess the feasibility and utility of these tests of exome sequencing and actually bringing them into the clinic. Obviously, pipelines have been developed both in addition to the research setting and the clinical setting for how to store, analyze, and process these tumors. Importantly, we're not just finding the results of these exome sequencing studies, but also assessing the preferences of the oncologists and the families for how we report this type of information. So, for example, the meeting where the oncologists and genetic counselors give the results back to the families are audio recorded and then analyzed by folks expert in doctor-patient communication and communication of genetic information to try and assess what kind of questions are asked, how are these results explained, what results do the oncologists think are relevant to their patient, to try and get to some very practical hands-on experience with doing this. In addition, the oncologists and the family members are surveyed and interviewed at various time points to try and assess what they think of the data. Fourth, we are finding potentially actionable mutations, although we're still figuring out how to use that information. And obviously, we learn more about the biology of these tumors. I'll just point a couple of key challenges as we go into the second set of case studies. The first is we're obviously just using exome sequencing as the clinical test for this study, but that's in reality not going to be the test of choice. So it's going to be a combination of questions for each patient. What would make the most sense, whether it be a targeted panel, exome sequencing, genome sequencing, RNA sequencing, arrays, epigenetic analysis. Trying to figure out how to put all this data together is one of the big challenges. And so a second question in this study is in addition to doing the clinical exome sequencing, we ask permission from the patients and the families to do all of these other sorts of studies, RNA sequencing, et cetera, on these same samples. And we're just trying to see what types of mutations, what types of alterations can we detect. It's not clear how that will yet be applied. The second is what looks very straightforward on paper in terms of identifying a mutation, a particular oncogene or tumor suppressor gene. It's much more complicated, as everyone's heard today, when you're trying to think about the patient. Questions such as which of these mutations are actually functional. It's one thing if you know what the important gene is, but say you find a missense mutation in that gene that's you don't know anything about. You have no functional data, no in vitro, no in vivo data. How are you supposed to decide whether that's truly an activating mutation and whether you should give that patient an inhibitor of that mutation or that gene or that pathway? Even if you're confident of that, what's the best drug to use? When do you use it? In combination with regular therapy? After additional therapy? Do you try and replace standard chemotherapy? And what evidence of potential benefit do you need to give it to your patient? It's obviously, if you're many cases, we're trying to make decisions when we have very limited options for our patients. So of course, the impetus to do something, to try and take some action, to use some drug that makes sense on paper or in the laboratory is huge from both the patient and family perspective and from our perspective. But the question is, how confident do you need to be of that before you put that patient through either a clinical trial or giving that drug or subjecting them to those potential toxicities, let alone questions of costs? And finally, which I didn't really dwell on at all, but how in terms of just making the point that we are finding germline in addition to tumor data here. And so we need to think about how we're going to interpret these findings in terms of cancer-related susceptibility mutations and then other potentially medically actionable mutations. Already in this study, we have data from on the order of 70 to 100 patients, and we've seen mutations in genes causing long QT syndrome. We've seen pathogenic mutations causing familial hypercholesterolemia. We've seen mutations causing mitochondrial disease. And these are things that are picking up, and you can bet that the oncologists are not always that excited about finding out those results. But the question is, from the family's perspective and the patient's perspective, how can we make use of that info? So a number of people involved in these studies and these projects. These are the folks, Robin, Sarah, Katie, Stephanie, who actually do the work. Sharon Plon is my partner on the project, and it's being done in conjunction with the large-scale sequencing center at Baylor with Richard Gibbs. Angshumoy Roy and Lola Lopez Tirada are the molecular pathologists involved in the study who created many of these slides. Then our oncologists, our surgeons, and a number of other folks in addition to the research funding. That's just a small sampling of what it takes us to try and answer some of these questions. And we'll stop there and move on to the next talk. I think we're going to have questions after the second talk.
Thanks, Will, very much. I know how difficult it is in a short period of time to present some of these complex case studies, so really appreciate boiling that down for us. One more case study from a local, Rob McWilliams, I'm going to invite out. He is a consultant here in the Division of Medical Oncology at Mayo, and also happens to be a professor in the College of Medicine. And he is going to be sharing with us some of the experiences and case examples from the Mayo Cancer Service line, in particular talking about some of the outcomes that they've seen from interventions, as well as some very practical insights about how you can really infuse this into the practice. So let's bring out Rob.
Good afternoon. Thanks for hanging in there. I'm going to give a couple of case examples today. For those of you at the Omics 101, I described our process. We have an individualized medicine consultation service open for the past year or so, and these cases are selected from examples from that. I'll just go straight into the cases. I won't go through how the whole clinic is set up, but our first patient, one of our earliest patients actually in the service line, a 44-year-old woman who'd been diagnosed with cholangiocarcinoma. She was stage 4 diagnosis with primarily lung metastases. She was treated with standard of care gemcitabine and cisplatin and had some stable disease, had done fairly well, but then eventually her disease progressed as is expected. She then enrolled in a phase 1 trial here of single agent pazopanib, which is a multiple targeted TKI that is now in clinical use for renal cell cancer and other malignancies. Actually had a partial response, and I'll show some images from that in a moment, but then eventually had slowly progressive disease. So she came to our individualized medicine clinic, and we did a consultation with her and talked about the various testing that we could do. At that time, we had her meet with one of us. We have 4 oncologists that are doing these consultations. We then set her up to see a surgeon, as our service line have required prospectively obtain frozen tissue for our exome analysis. Our pathology was set up so we could process that frozen tissue in a CLIA setting and in a clinical setting to be able to get that for analysis. And also review it for cellularity to make sure there was adequate cellularity so we didn't get a false negative result. She also met with our genetic counselor, who we call our genomic counselors, to really talk about the implications of genomic testing, the limitations of it, potential costs involved, and any incidental findings that might pop up that might be unexpected. Our panel at that time was, we had used, as a short turnaround, we did Foundation 1 panel test, which is a 250 gene commercially available test. It's a fairly rapid turnaround in 2 to 3 weeks. We also work with our colleagues at Baylor, who have a clinically available array, basically comparative genome hybridization to look for copy number variation in any individual's tumor type. And then also work with Baylor to do exome next generation sequencing to look at the entire exome. Now that generally takes some 12 to 15 weeks or so, so there'll really be a couple different time points. We then meet as a genomic tumor board, and that board involves oncologists, genetic counselors, pathologists, ethicists, basic scientists, and we really try to discuss results very commonly to what you've seen also presented today. So just an example of this patient's foundation report. Very interestingly, there was a fusion gene in FGFR2 and TAC3, and that actually our colleagues in Arizona doing a separate research project had seen a similar finding, and so that led to quite a discussion. Around that time also, the University of Michigan published a series of cholangiocarcinoma patients with these rearrangements. They'd been previously reported in glioblastoma, but was new for cholangiocarcinoma. What was really interesting, that's potentially druggable. The patient also had some other abnormalities noted in BAP1 and then GNAS as well. Comparative genome hybridization, we had fairly complex findings. We had copy number loss in a number of different chromosomes and gains in a few more. Interestingly, FGFR2 was located very near an area of loss, so would make sense. Exome sequencing eventually came back for this patient. It confirmed a somatic truncating mutation in BAP1 in only 15% of cells. So again, that might be a subclone, but we had about 80% cellularity in the original lung biopsy section. So we knew targeting BAP1 in this patient wouldn't necessarily target all of the malignancies. And that's going to be an important component of looking at a report. BAP1 is involved in histone deubiquitination, and that'll be more important for case 2 than for case 1. Interestingly, the exome did not call the fusion gene, which makes sense because actually the point of fusion is in an intron in FGFR2, and then it did not call the GNAS mutation, nor did another commercial exome. So again, all these findings, there's various cutoffs, and any bioinformatician will tell you how you design the cutoff. You may or may not pick up various findings. So for our results, we felt the fusion gene in FGFR2 and TAC3 was felt to be potentially most targetable. And again, I mentioned there was recently reported to be present in a number of cholangiocarcinoma patients and also prior GBM. Now the patient had that partial response when they were on pazopanib on that phase 1 study. Now that is a tyrosine kinase inhibitor. It does have some activity against FGFR2. So it may well be that because of that fusion gene, that was a key driver, and that's why that patient responded. It's hard to know for certain. Nonetheless, as a tumor board we discussed and said, well, actually there are some FDA-approved available agents that specifically target the FGFR pathway. One example being ponatinib. Now, ponatinib was approved in December 2012 for CML, but it's available and on the market, and we decided, well, let's try to get access to that. So these are images from the patient's lung metastases while they were on pazopanib. And just one example, so you had a very good partial response. So this right lung lesion was present at the baseline scan, and after 4 months on therapy, this was the lung lesion. So a pretty impressive response. Not all the lung lesions went away, but she had a good response. We were able to obtain access to ponatinib after working with a pharmaceutical company and the patient's insurance, and got her on ponatinib. Now this is after she had already progressed on pazopanib, and this is a different lung nodule. But this lung nodule here on the right side maybe got a little bit smaller. This was a different cut, so this was still present. But this was maybe a little bit smaller. So this patient actually ended up having very minor response, stable disease for 4 months after therapy. Unfortunately, it eventually progressed. But FGFR fusions are present in cholangiocarcinoma. We've done some studies here to try to find out the frequency, be able to develop some in-house testing to be able to identify these patients clinically in a fast way. And actually, we're in the midst of developing one clinical trial in cholangiocarcinoma specifically, and then also another trial targeting multiple different malignancies with findings such as this. So really an example of how you can take clinical information, learn from the clinical patient, and then develop it into a research study. So our patient number 2, it's a 39-year-old gentleman with metastatic meningioma. At the time, it was metastatic within the central nervous system, but he had some interesting lung nodules. He had been previously treated with proton beam therapy and hyperbaric oxygen, and as a result of the hyperbaric oxygen, had some pulmonary complications. He had just been treated with temozolomide and then progressed on that and came to our individualized medicine consult. He had these new lung nodules which really hadn't even been biopsied yet. He also, interestingly, had a history of follicular thyroid cancer just 2 years prior to his diagnosis. So the patient had had a previous pneumothorax on the right, and then when he saw us in our individualized medicine clinic, we unexpectedly diagnosed a contralateral pneumothorax, so he had to have surgery anyway. So he called one of our surgeons who was very interested in genomic testing and said, while you're in there, could you go ahead and resect some tissue for us? And so it worked out well. He was in the operating room the next day. We were able to confirm the diagnosis and get our tissue for genomic testing. Now, like any good rare malignancy, we started asking around and say, well, meningioma, metastatic to the lung, is that something that you actually see? And one of my colleagues had maybe seen one 10 years ago and went to the literature, and sure enough, there's a Mayo Clinic series on meningioma metastatic to the lung. It consists all of 3 patients over about 40 to 50 years. So it does happen. So after we got our genetic results back, it revealed our panel test revealed a truncating mutation in BAP1. Again, that deubiquitination gene that I mentioned before. Now, BAP1 is interesting because it's also an important gene for ocular melanoma, and it's present in high frequency in that disease. And there's actually been some therapeutic implications and people doing some laboratory and in vivo work looking at targeting melanoma cell lines that are knocked out with BAP1 with HDAC inhibitors. And there's been some very interesting findings along those lines. So that we thought that was potentially interesting. The comparative genome hybridization was also very interesting in that the only abnormality was the loss of a copy number at that site. So with a truncating mutation in BAP1 and a loss of heterozygosity in the other allele, we thought, boy, that's a very interesting tumor. We also have to realize, though, if we want to practice individualized medicine, we have to talk to our patients to get a sense. So we thought this might be germline, this might be very interesting, might explain his thyroid cancer. But the patient very adamantly did not want to know, is this a germline abnormality? So for that reason, we didn't even proceed with exome sequencing because you need germline evaluation as part of that. And he was very clear he didn't want that. So we had to go on what the information we had. Didn't find any other genetic abnormalities, so BAP1 was our target. We then discussed our genomic tumor board and decided to recommend HDAC inhibitor therapy because there were no known standard therapies to help in this patient's circumstance. It took us about a month to get access to an HDAC inhibitor we used for Inostat. Patient, when he got it, tolerated it well. He had stable disease for about 2 months or so, but had multiple intercurrent medical problems and hospitalizations. Eventually had progressive disease. So I think these two cases are examples of findings of potentially targetable lesions. We can get access to a medication. Sometimes it has a clinical benefit, sometimes it doesn't. But I think one of the biggest challenges as oncologists is, okay, we found this target, it makes sense, now what? Sometimes you have clinical trials that might get you access to an agent. Sometimes that might be a trial in another institution. Sometimes these agents are available on the market, but at an extremely expensive cost, $5,000 or $10,000 a month. Sometimes, surprisingly, they're covered by insurance, but most times they're not. So really, it's a big challenge, and I think that's one of the hardest conversations to have with patients is that we found this finding in your tumor, we think we can do something about it, but not right now, or not here, or we have to go through these other hoops. But I think for persistence, a lot of times you can't get access to these drugs for patients. It does leave us with some questions, though, as well. The cost, is it worth it? You've heard a lot of stories and anecdotes at this conference, and we all think we have an idea of where this field is moving. But can we prove that we can benefit patients at this point? Do we have large-scale studies that show genomic testing is better than standard of care? I don't think we're there yet. I think we're still trying to get a sense, what's the water temperature? Am I comfortable in this environment? What's the best way to do this? But I think this is coming. Right now, the clinically available tests that we do in our clinic don't take into account things like tumor heterogeneity, multiple clones being present. We can get a sense in that from the percent of cells that have a particular mutation, but it's not really the robust analysis that we'd like to do. So I think we have a ways to go in the testing we can do. And I think the future may hold multiple assessments of the tumor over time. How is this cancer evolving? Once I put this selection pressure of a therapy on it, what's it going to do? How's it going to change? What pathways can be upregulated to compensate for those? I think that's the tremendous challenge. We've heard a lot of speakers and great scientists at this conference who hopefully will point us in the right direction. So with that, I think we're ready for questions.
Wonderful. Thank you for that, Rob. Quick tour of the landscape. Well, this is a chance to ask Will or Rob, or the two of them, any follow-up questions on some of these case studies before we have a chance to go into the poster sessions and reception, I might add. And I certainly have a couple, but I wonder if we have any come in from the audience as well. But I can certainly start, and I think this is one that I would pose to the two of you, and it's just a question around this notion of, should individualized medicine be a subspecialty, or is it an area that any oncologist can practice individualized medicine with the right tools? Want to start, Rob?
Well, that's actually a great question that we've debated in our own group as well. Should this be an area, because the landscape is so unclear at this point, how it's going to be implemented? It is something that we want to have certain oncologists have an expertise in, or really just let it dissolve throughout the practice. And I think the answer is both. I think certainly there are aspects of individualized medicine that we all can practice and all integrate into our practice. And someone who knows brain tumors much more than I do will certainly have a much different lens as to selection of therapy than I would, just looking at a genetic report. But I think there are a lot of nuances and limitations to genetic data, which most oncologists are not particularly aware of. And I think there's got to be a group of people who are more involved and more heavily involved in discussions to be able to diffuse that throughout the practice. There are certainly a lot of panels out there, and I mentioned the foundation panel, where certainly the reports are to a quality where I think a clinician could very easily just take that and run with it. I think there are a lot of other more exome and genome and RNA sequencing where it's much more nuanced, and I think the clinicians be part of a larger team to really understand that.
Mm-hmm. What do you think about that, Will?
That's a great point in general. I think that's one of the big questions that we have actually in our study as well, is we are studying essentially a practice of 16 oncologists and how they make these decisions for their patients. Mm-hmm. And that's a group that's in general relatively, it's in an academic setting. They're exposed to geneticists and a little more of kind of some of the details of what's going on in these methods. And it's also a group that really acts as a group. So each oncologist doesn't necessarily make individual decisions, but they kind of consult the brain tumor team if they have a brain tumor patient, et cetera. So it's really a gathering or a conglomeration of multiple opinions and expertise. So thinking about comparing that situation to an individual practitioner in the community who has not been exposed to some of these methods, or kind of, as you're saying, the discussion of the uncertainties of the methods, it's a very different scenario. So we're hoping to study it first in a very defined setting, and then it'll be a very interesting question to see how that's applicable.
How you expand it. Yeah. There's a question, Will, from the audience, and they ask, was sequencing the parents of the patient with the WT1 mutation considered?
It's a great question. So on our study, we do ask for blood samples from all the parents of the children who are enrolled in the study, specifically for the purpose of interpreting any genetic findings that we see in the child. So if we see some pathogenic mutation, the first question is whether that's de novo in the child, whether it's inherited from one of the parents, and that has obviously huge implications for how we counsel and explain risks for other family members, other children, siblings, etc. In this case, where it was a mosaic mutation, the results were discussed with the family. And I think blood testing has since been done, but I don't know the results of that. So our expectation is that will actually be negative, that this was a new event occurring in the development of that child, but that will be confirmed.
Here's one for you, Rob, and it asks, in your practice, who do you decide to do whole exome sequencing on? And maybe share with us a little bit about what goes into that decision making. Well,
at this point, it's an evolving picture. Really, initially when we started our clinic, we really wanted to do whole exome on everybody to get a sense of, okay, what are the right tests to be able to do. Now, with the results of panels and CGHs coming back in just a few weeks, it seems to be a much more rapid turnaround and clinically meaningful turnaround for patients who often have very little therapeutic options. So for most of the patients that I see now, we're basically starting with the smaller panels or maybe a CGH, and then saying, okay, if that's negative, then we still go out to exome, because exome really does require, at this point, frozen tissue and prospectively collecting that, whereas for other patients that maybe want to do a panel test, we can use archived tissue. So that's a lot of consideration. In addition, oftentimes we can pre-authorize whether or not the exome will be covered. If it's not covered, that's a $15,000 cost to the patient, which is not trivial for most people. So I think that's a large part of the discussion.
Yeah. This is something that dawned on me, and I see there are some folks in the audience that are asking versions of this question as well. And it has to do with, you know, again, to the layperson, to patients, family members, you start hearing about genomic medicine, and you can really very quickly get quite excited and get your hopes up about this new cutting edge therapy, if you will. So how do you handle the conversations around expectations for cancer patients and their family members when you start heading down the path of genomic medicine? Will?
So this is something we run into a lot. So either in terms of trying to explain, for example, for patients who are considering enrolling on a study of genomic testing, or for, say, a recurrent tumor patient whose family is desperate for any answer and any new treatment, who are obviously very motivated to try something. And we do two things. One is really in terms of, especially for the patients who are enrolling in our study, if anything, we try and undersell the potential benefits of this. I mean, really make the general point that, you know, they're helping us learn about this. We have no anticipation whatsoever. We have no real understanding whatsoever if it'll actually help their child. We hope that it will, but we really don't have any understanding of that. The second part is that we try and make it clear what some of the caveats are. So some of the topics that we talked about here in the cases today and have been in other sessions as well, just trying to make it clear all the levels of uncertainty that we have. So if, you know, the number of cases where you have a specific mutation found in a specific gene, found in a specific tumor type, that there's a specific drug targeting that mutation that you know in fact will help that patient, those are really relatively few and far between at this point. And frankly, if those were all certain, then you would have detected it by testing for that particular gene or mutation in that tumor type as part of standard clinical care. But that there's uncertainties at every single step of that process, from different mutations to, even if you know something about the gene, you don't know that much about the specific mutation, to even if you understand the biology, trying to figure out which drug might be best or how to use that for their child. So we just try to emphasize that.
How do you handle those expectations in your practice?
I think it's natural for families and patients to have the expectations, and I think they're not only looking for how do you treat my cancer, but maybe even an explanation why it has happened to them. And I really try to address that and say, you know, those are very valid questions, but we likely will not find out why, and we may not find a target. I think that's one of the most difficult aspects, is really, even when we tell them that, sometimes when you have to have that conversation and say, look, we did this and we don't find anything actionable, but look at this appointment, it's very real. We're also dealing with a patient population that really doesn't have a lot of therapeutic options. We've elected to really do our personalized medicine in a group of patients who have basically exhausted standard therapy. So it can be a difficult problem.
And do you think that, though, that dimension, that so many of these patients have exhausted the other options, is why you get the participation level? Because if I were the patient or the family member listening to the two of you here today, lowering the expectations and all of the uncertainties, I might just say, well, why bother?
Yeah, I guess in the case of our study, for example, we're enrolling newly diagnosed patients, so they're not in the same clinical, kind of desperate clinical straits, except for specific diagnoses that Rob was talking about. The second thing I would say is that the motivation of the families of our patients to feel like they are contributing to our knowledge and helping us to learn about how to treat the disease is, you cannot overstate how strong that is. So if we have a study such as this or projects such as these that we explain what we think the risks and benefits are and explain what we think it might do to both, in theory, help an individual child, but hopefully children in the future, they are remarkably enthused about doing that in general.
Wow. That's great. Rob, I see a question here directed to you, which is, why would a patient not want to know if his disease is attributed to his germline? Does that come up?
Yeah, it does. I think and our genetic counselors will tell us this quite often. Patients, really, when they're getting cancer treatment, they're focused on their disease and treatment for that. They really often may not want to be burdened with the other implications of having a germline mutation, risk for family members, things like that. So a lot of times emotionally, it can be just too much burden for a patient who's really focused. I just want to find a treatment for what I want to do now. I don't want to worry about that other stuff. And so we respect that. I mean, I think we really be as clear as we can on what are the chances of that. And then once they make that decision, we respect it.
And Will, this is a question that came in on specifically the osteosarcoma case that you presented, the 14-year-old. And the person out there asks, how do the exome reads or the mutations correlate to the karyotyping, the multiple chromosome abnormalities?
Yeah, so that's a question that brings up one of the key points, and which is really one of our goals here is to try and incorporate all the information we possibly can about the patient into one picture and one understanding of what's going on in that tumor.
And are you using an EHR, as we heard discussed in others this morning?
So in our case, we have it's kind of two pieces. One is a research database where we're tracking specific genetic mutations, clinical outcomes, et cetera, to try and, on the research side, put things together. On the clinical side, the exome reports from the tumor in the blood go into our electronic medical record just like any other report. It's not currently in any very sophisticated way. So if you go into the medical record to look for the report, it's just there as a cytogenetics report or another report. We have been working on developing first an iPad app and then also a web-based interactive feature such that when the results are being shared with either the oncologist or with the families, that they can click on a specific gene to see what that might be, and they can get definitions of some of the terms, and the oncologist can kind of quickly look through what's known in the literature, for example, about that case. So that's what we're trying to do.
I think this is a good one for both of you, and it asks about the use of cancer drugs off-label, which of course means you're using that therapy for a different kind of cancer, typically not the FDA recommended. And it asks if you're doing that for patients on a research protocol and your sequencing findings suggest the drug may be helpful. Are you at that point in this process?
So as I explained in our cases, we've done that several times already. I think, in our situation where patients don't necessarily have other therapeutic options, we feel more comfortable doing that. And we've had actually pretty good luck in getting coverage for a number of our patients for that type of therapy. Obviously, we have intense discussions with the patients saying these actually are the risk to these medications. They understand it's off-label. They're not approved for this type of malignancy, but we do that both on and off protocol. So maybe patients are not on research protocol, and we still can treat them that way because we have a CLIA certified test that we're doing. We are developing some research protocols where the genomics would then assign a patient to a treatment arm based on their outcome of the genomic analysis, but those are in development currently.
What about off-label for your purposes?
In pediatric oncology, we use virtually everything off-label.
Of course.
So it's
sure.
It's almost there's that. In terms of our research study, we're not dictating treatment. So we're not, for example, saying that if we find a particular mutation, the patient will receive some off-label drug. But one of the interesting questions is what decisions like that are the oncologist and the family's going to make between them about that use.
Right.
So obviously the huge practical question is related to cost, insurability, and that sort of thing.
This question is right up my alley because probably because of a lot of my work in Washington, where so much of the discussion right now in healthcare is still about cost, or if you're lucky, value, and reimbursement. And obviously much of this conference, that theme keeps coming up as well when we're talking about individualized medicine, genomics. And this person presents the question of, when you're talking to insurers, and I don't know if either of you do this directly, but I bet you have some...
Not if we can avoid it.
Exactly, right. Have somebody else talk to the insurance folks. But do you have a sense that when you're discussing reimbursement with them, are they more concerned about the cost of the test, or are they fundamentally concerned about the cost of the therapy? Or is it just both and they don't want to pay?
So I have not done that talking directly. What I can say is that, speaking from the experience of for example, the Baylor Clinical Lab, which I'm not a part of, but which I observed, they actually have had quite good success at getting insurers to pay for both germline and tumor exomes. The rationale has been stated in some of the other talks relating to the cost of an exome, for example, versus the cost of a panel or targeted gene testing. You can make the argument for the test itself that often, if obvious answers have been excluded, it's a rational thing to do.
Right.
I would suspect the greater problem would be related to the therapies.
The therapy itself. Is that your sense of it as well, Rob?
That's my sense, but I'm not sure insurers realize that. They often don't get past the sticker price of the test before realizing the downstream implications of what we're going to do later. So it's more really two separate conversations we're having currently.
Right, and I imagine having to spend a great deal of time educating them on what you're doing and the progress being made and hopefully the impact that it can have.
Right. I think that's right.
So to clarify, in our study, for example, it's all being paid for by research. So our families aren't paying for any of it.
Sure. Right, that's a very good point to underscore.
It would not make sense to routinely order exomes for all these patients.
Right, and I think that's been a thread throughout so many of the conversations today and yesterday are these organizations that are represented that are investing in this research, which is obviously very costly. Might have time for one or two more. I see one here about whether your perceptions or maybe your colleagues' perceptions of genomic data usefulness has changed in the last few years.
So I wouldn't say that my perception, I don't know about my colleagues, but my perception of the usefulness, I wouldn't say it has changed. I'd say we're still very excited about it.
So you were bullish back then and you remain.
Yeah. However, what we've spent more and more time thinking about, and what is either the half glass empty versus half glass full approach, is we've become much more fixated on all the various challenges of how to overcome this. The challenges of interpretation, of tumor heterogeneity, of changes in the tumors over time, of trying to select which drugs. So we're now at the point where it's very exciting in concept, and I think the ideal is still very important and very theoretically feasible. But we're currently engaged kind of in the trenches, so to speak, with some of the realities of the situation. More maybe than we were a couple years ago, probably the same, but more 5-10 years ago where we had hoped that it would be a simpler story.
How about your perceptions, Rob? Have they changed?
I'd say they've evolved to some extent. I mean, we certainly, I think, now are in an era where the low-hanging fruit, we can do a panel or look for things where we know what that gene does, we may have a drug against that gene, and we can skim those off. And I think that's going to be a small percentage. I think the larger understanding of take the average cancer and be able to say, okay, what is the driving pathway? How do we put this whole piece together? That's not here yet. And we're evolving towards that. And I think hopefully we'll be able to move that forward and really affect the majority of patients now. But I think the patients that, if you look pretty consistently, if you look at all the clinics that are doing this, the overall clinical benefit rate is in the 10 to 20% range for all patients going in. So we're just skimming out the surface right now. I think we're going to get there. It's going to take time. It's going to take concerted effort. It's going to take a further revolution in the understanding of cancer biology to put it all together. But I think we're going to get there. I don't know when it's going to be, but it's on the horizon.
Well, then I'm going to pick up on that moderator's privilege to use the final minute here to toss out just a really simple one for the two of you, which is look into your crystal balls. We're back here in 10 years, or Gianfranco hopes maybe we're not because it won't be so necessary or this will be happening all over the place. But 10 years from now, what does this field of study look like?
That's the simple question.
That's the simple one. Yeah, then you get to go have a drink at the poster reception.
I think in the next 10 years, hopefully we're going to have made a huge amount of progress in terms of kind of the bioinformatics and the conceptual understanding of not only what are all the types of genetic alterations that we have, so that information will just be essentially known. The methodologies, et cetera, will be somewhat standard. But then more importantly, in terms of how to interpret that and match it up with drugs and with functional data. So kind of those pieces of the puzzle, I think, are where the progress is going to be made. And that's what I think is going to make the biggest difference.
And Rob, what's in your crystal ball?
I think it's going to be very similar. We're really make it into serial sampling. A patient knows that, okay, my tumor started with this, now it's doing this, and this clone's still there, and what do we need to do about this, these two clones? I mean, I think we're going to eventually be at serial sampling of these. May hopefully be within 10 years.
Wonderful. Before we thank our two kind gentlemen, reminder, poster session, reception, just out and to the left. We'll see everybody back here tomorrow morning, bright and early. And let me just say to Will and to Rob, thank you both.